Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today is Thursday, September 10, and you have joined us for an opportunity to ask me questions directly about COVID. You can put questions in the box below. You can also put them on either Facebook or Twitter with the hashtag AskDrArwady, and we will be taking live questions as well as answering questions that have come in over the last couple of days since our last Facebook Live. This is a slightly different time for us to be doing this update, and that's because today at 11:30, the mayor, the Department of Water Management, and I will all be part of a press conference about lead service line replacement here in Chicago. So a reminder that the Chicago Department of Public Health does work on some things besides COVID, and certainly preventing lead issues in Chicago has been a priority for a long time. So because of that, we're earlier than usual, but and you'll see we don't actually have a guest today. So I will just be directly taking some questions, and we will see how it goes. Since I don't have a guest, I don't have to demonstrate social distancing, but just a reminder, this is a very easy way. If you and everybody around you is keeping this amount of distance, that really helps decrease the risk of COVID spread. Also, obviously, continuing to wear that cloth face covering and making sure that you're doing the hand washing, protecting people who are most vulnerable for serious COVID outcomes. So let's take a quick look at our data, and then we'll dive right into questions. So as always, you can go to chicago.gov/coronavirus. Right up at the top is latest data. You can get all kinds of details, or you can get directly to the daily dashboard by going to chi.gov/COVID-. And we'll pull that up now. Do we have it up? Great. So first of all, if we take a look, our current positivity rate, that's the test positivity rate, the number of positive tests divided by all the tests that are done. Even if someone has had multiple tests done, all the individual tests are counted. We are at 5.0% now. You can see last week we were at 5.1%. We'd been in the just over 5% range, and so that's come down a little bit, which is the way we want to see it heading, but I want to see it get even lower. Similarly, our cases down at the bottom here, where we've now had a total of almost 74,000 lab-confirmed cases of COVID-19 just in Chicago residents. We know there are many more, probably 5 times that many at least, people who have had COVID-19 but did not have a formal lab diagnosis. But regardless, our daily case average at this point is down to 304 cases per day. And if you've been following along, that is definitely an improvement from where we've been over the last couple of weeks. We had peaked this time around just over 350 in our daily case average. And as a reminder, we really don't want to get above 400 cases per day as our rolling average, because that marks, an even higher level of concern. It is also equivalent to the level where we are requiring that quarantine for people returning from states that have that level of COVID infection in their state. So pleased to see that heading in the right way. You can see compared to a week ago, it's down about 9%. And that's in the context of testing numbers staying relatively stable. We've been in the 7,800 to 8,200 tests per day mark. If we go up on the top here and click over to daily by demographic, this is where you can get a little more sense of what's going on under the surface of those numbers. So first of all, first again here on the left, this is just our overall confirmed case number, holding it just over 300. But this is where we talk about not just the number of tests done, but the number of people who are being tested. And this is where we what's called deduplicate, meaning if someone gets multiple tests because they live at or work at a long-term care facility, or they have other high-risk exposures, they only get counted once. And so you can see that this is our number of people tested, and then our people positive, so while our test positivity is at 5%, and that's the number that the state uses and is really the top number for comparing across regions, our person positivity rate is still at about 7.7%. And although that's come down, you can see last week it was up to 7.9 or even 8%. That's really, we want to see that in particular come down. This is not just about changes in testing. If we were seeing a decrease, I want to see that decrease in case numbers. I also want to see a decrease in percent positivity. If we look quickly at race ethnicity breakdown, If I click here, there it is. So this again will let you look every single day going all the way back to the outbreak, what race and ethnicity breakdown has looked like. And if we focus particularly on the blue line here, that is for Latinx, so Hispanic or Latino Chicagoans. You can see the very high surge in Latino cases back in May has come down, and we've seen the highest disproportionate number of cases in that group over the last couple of months. And that also, if you look just over the last couple weeks, has been coming down very nicely. If we zoom in for a second, I'm going to bring it and just show you what the data looks like, say from like early August to September, and then blow that up. You can see that blue line here. We're seeing some very nice decreases here. So that's really good. Thanks to everybody who's been working hard to make sure that testing is getting out in those communities, and resources and information and linkage to care, all of that. That's some good progress we want to see continue. Similarly, I'll just highlight the purple line here are people who report Black, non-Latinx race ethnicity. And that has been a continued very nice and steady decline over the last couple of months. We're seeing lower case rates at this point in Black Chicagoans than we are in red in white Chicagoans. Green is Asian, and yellow is people who report other race ethnicity, but non-Latinx. So that's all heading really the way we'd like it to head, and I'm very hopeful we'll continue to see progress. Let's take a quick look at age too. If we just keep that over the last month, and I'll blow it up, if you've been following along with us, this red line on top, that's our 18 to 29-year-olds. You can see that group still is disproportionately where we're seeing cases. They're our leading group for COVID cases, but you can see this also has seen some nice decline over the last couple of weeks. So pleased to see that progress. Very pleased to see down at the bottom here in pink and gray, that's our over 70-year-olds and over 80-year-olds. Those rates have remained very low. Those are the rates I most want low, because that's what helps keep people out of the hospital or keep people from dying. Obviously, those folks at higher risk for serious outcomes, although we see serious outcomes in people of all ages. Dark blue here are our children, 0 to 17. So overall, some cautious, better news on this front, but we need to continue to see this progress over September, especially as we're heading into cooler weather. We're going to start losing our outdoor opportunities just at the same time that we know our traditional cold and influenza season are coming. So now is the time to start getting your flu shot. All right, let's go ahead and turn right away to some questions. All right, Brianna Gonzalez on Facebook. Why do people have to wear masks but not at swim schools? She says instructors are picking up students, may be in touch, there may be water resistant masks. Why aren't those mandatory? So what I will say is that I am not aware of a mask that really is particularly effective in a water type setting. Certainly, if you have a child or you yourself has an underlying condition, or there's someone in your bubble that has an underlying condition or is over the age of 60, now may not be the time to be taking swim lessons. It's kind of like eating at a restaurant. You can't, people need to take off their mask to eat. I would argue largely it's very difficult to have a mask on when you're in the water. I shared information at the press conference last week about a pool party here in Chicago where we had seen significant spread. It's great if people can wear masks when they're out of the pool, but I don't think it's realistic to require masks when people are in the pool. The sort of masks that you might wear that are a complete seal, that you might wear with a snorkel, I suppose, would be one possibility. But really, my main guidance would be, swim school would be one of those activities that is just higher risk by virtue of the type of activity that it is. So thanks for that question. James Bossman on Twitter. What are the possibilities that other airborne irritants, such as household pest control sprays, large-scale Monsanto products, for example, or pollen, could cause false COVID positives? All right, good question. Zero possibility that pest control products, Monsanto products, pollen could cause a false positive for COVID. And that's because the way the COVID tests work is that they are literally looking for the presence of COVID, and they're either looking for the presence of the actual RNA, meaning the genetic material of COVID. That's the main type of testing, the diagnostic testing that we have, or they're looking for the protein that the virus actually produces, and that's the antigen testing. Antibody testing, which is the blood test, is looking for the immune response to COVID. But these are all very specific to COVID, and I have zero concern about false positives from exposure to any of those. So good question, but not a thing to be concerned about. Thomas Downing on Facebook is asking, how long do the symptoms last? And we've had a number of questions, I know, actually, about this. We've gotten questions in about what do we know about the so-called long haulers who seem to have longer courses of infection from COVID. So let me give you the answer for what we know about acute infection and the risk of spread, but then also share a little bit of information about what we are starting to learn about some of the longer term effects. And the first thing I want to say is that we are still very much learning about the potential for long-term consequences from COVID. As a reminder, we've only known about COVID for 9 months, and to really understand what the long-term outcome is, you have to have enough time to actually follow people after COVID infection. But some of that studies are starting to come out. So first of all, how long do the symptoms last? The immediate answer on that is that we, first of all, know that there are people who do not develop symptoms at all or have very mild symptoms. And in that case, we recommend for people who have a more mild case of COVID that from the time that you are diagnosed or starting with the day that your symptoms begin. So if your symptoms start and it's a mild case, or if you don't have symptoms but you get a test and it's positive, that's sort of considered day one. We need people to stay isolated for 10 days from the time that their symptoms start or the time that their test is positive, and the last 3 days of the time period that you stay isolated, you need to be basically better. Your fever needs to be resolved, your cough needs to be nearly resolved, you need to be feeling good. So the least amount of time that somebody needs to stay isolated, even with very mild or no symptoms, is 10 days. The longest is however long your symptoms last, because those last 3 days, you really need to be basically symptom-free. But to the larger question of what do we know about some of these longer impacts of COVID? I am keeping a close eye out for studies that are starting to answer this question. And there was a study published August 25th in the Journal of Infection by an author. The first author is Garrigues, Garrigues, if you're interested. And this was basically a study just out of one large hospital where they followed up. They did phone call follow-ups for anybody who had been diagnosed with COVID and admitted to the hospital. So importantly, these are people who were sick enough to need hospital admission. And they did a whole set of standardized questions at least 100 days after discharge from hospital. So these are people sick enough with COVID to need hospitalization at least 3 months later to see how they were doing. And basically, these were people who were hospitalized back in March and April. So what they found when they asked was that of the people, about half the people completed the survey. So there's always some question about the people who don't want to complete the survey. Those people are probably doing a little bit better, or maybe they're not. We just don't know. But among the 120 people who completed the survey, 55% of them were still reporting some level of fatigue 3 months after admission. 42% were still reporting some amount of shortness of breath. 34% were reporting some potential loss of memory. 28% some potential changes in concentration, and 31% still some issues with sleep or sleep disorders. Most people, 69% of the people who had been working prior to their COVID COVID diagnosis had been able to return to work. So that suggests that most people had had at least enough recovery to return to work, although about a third of the folks actually had not been able to return to work. Interestingly, they didn't see any statistical significant difference between people who were sick enough to need to be in the ICU versus people who were sick enough to need to be in the hospital but not in the ICU, except a little bit of a difference in pain. So people who had been in the ICU were reporting some more pain. But besides that, this is one of the early studies that's just starting to get a sense of some of the longer term symptoms that people are starting to have. This is just out of one hospital. There are much larger studies that are going on looking at not just what symptoms people are reporting, but that are taking x-rays and CAT scans and testing people's blood and urine and lung function that will be able to answer some of these questions on a more systemic level, but we don't have results on those yet. So the bottom line is we're still learning. There are also studies happening for people who had more mild diagnoses of COVID. Most of those people we think recover just fine, but there are some questions about potential longer term impacts. This came to attention particularly around children. A very small percentage of children seem to get this multi-system inflammatory condition. We've not seen that particularly here in Chicago, at least not in high amounts, but in parts of the country where there have been more children infected, it's certainly something that we're watching for, and we're looking back at some case results here to see if there's been issues. But we're still learning is the bottom line, and I really do want to remind people that I still hear people saying, "I think I should just get COVID and get it over with." That is not a good approach. You are not helping public health if you think that that's a good approach, because we do see people of all ages getting seriously ill, and there's still a lot we're learning about potential long-term conditions. I was very concerned, for example, there was a study where they were following up on college athletes who had been diagnosed with COVID and really, doing some echocardiograms, looking at their heart, seeing, in athletes even some potential for some changes related to heart function. Hopefully those are not long-lasting, but I really, you don't want to just get COVID and get it over with. We want to keep people from getting COVID. When we have a vaccine that is safe and effective, that will be the safer way to actually develop the immunity. So good question, and lots to keep learning there. Okay, we've got a question. Pam Petrowski on Facebook. My husband will be going on a trip to Florida. He plans to quarantine when he returns, which, assuming you're a Chicago resident, is good because he's required to. Florida remains on that quarantine list for having an average of more than 15 cases per 100,000 per day. They're making good progress. Pam says, I won't be visiting. I'll be staying home. Will I need to quarantine myself, and what are my options? So, great question. You do not need to quarantine yourself if someone in your household is needing to travel to an area that's been quarantined. But what I would very much encourage you to do is during the 2 weeks that your husband is quarantining at home, try to keep your distance even within the home. It's not a very high risk setting where we know someone has already been diagnosed with COVID, but when someone has traveled to a higher risk setting, and my guess is if he needs to do the trip, there may be some exposures of higher concern. Of course, I don't know that without the details. But I would just encourage you to, try to keep your distance when you're at home. If it's possible for your husband to sleep in a separate room from you for 2 weeks, I would recommend that. When people have been diagnosed with COVID, we also recommend that they use a different bathroom if that's possible. If that's not possible, if you want to be extra careful, your husband could also think about using the separate bathroom if that's possible. If not, lots of hand washing, just being conscious. You could even wear the mask if you were at home and wanted to be extra careful. But there is not a need for you to quarantine yourself. And thank you for the question, and thank you to your family for being serious about really reducing the risk of the spread of COVID to others if you do need to travel to somewhere with the quarantine order in place. Okay. Actually, here's a question about the upcoming press conference. Susan Villanosa on Facebook says, is there a plan to test for lead in all Chicago homes? There is not a plan to test for lead in all Chicago homes. What there is not just a plan, but a really it's a requirement that in the city of Chicago, all children should be getting tested for lead at age 1, age 2, and age 3 at their well child visit with the pediatrician. This is an easy finger prick type test. Some pediatricians do a blood draw, but typically pediatricians check a finger stick for lead and for anemia, low blood counts. Really important that that's happening when kids are 1, 2, and 3. Another good reason, if you have a young child and you've been putting off that well child check, get them in to get that to get that test done. Anytime a child, the Chicago Department of Public Health receives all lead testing results for children, and anytime a child is identified with a high lead level, we actually jump into action. We have nurses who reach out to that family to make sure that they're connected to the appropriate care and any other thing that needs to happen for that child. We also have inspectors, which depending on the level, will actually go into the home, work with the family, figure out how has that child been exposed to lead. The number one reason by far, historically and today, that we see lead poisoning in children is in lead-based paint, not water. Lead-based paint. We have a lot of lead-based paint still around here in Chicago, and particularly we'll see even in outdoor areas if there's lead-based paint that's peeling or it's not been kept up very well. Young children in particular can they're down and they're playing in the lead dust and they're putting their fingers in their mouths. That's the number one way that kids get lead poisoning. But if a child has an elevated blood lead level, we also will check the water, and certainly if there's an elevated lead level in the water, we work to make sure that there's a filter, and now there will be some more opportunity for actually replacing that lead service line. But anybody can get their lead tested for water, can get their water tested for lead in Chicago. Call 311. There's a free kit that's available through the Department of Water Management, and you collect it. There's instructions for how to do it. And for anyone who's found to have a high lead in their water, we provide actually free filters. This is not really a concern in large apartment buildings, I want to be clear, or in buildings that have, typically if there's at least 3 or 4 units in the building, the pipes are large enough that they're actually not the lead-based pipes, and so it's not a concern for larger multifamily buildings. This tends to be an issue in standalone single-family homes or 2 flats if they were constructed prior to 1988. So much more to learn about that, and I'm happy to get an occasional non-COVID question, but watch the press conference. We have a lot more online if you're wondering about lead. But I want to make the point that our water here continues to meet or exceed all of the standards for tap water. The federal ones, the EPA ones, the state ones, where we do tests for it. And so I don't want people being hugely concerned that there's been some major change in the tap water. There hasn't. This is us proactively starting to work on the legacy problem of 400,000 lead service lines that over decades are going to need replacement here in Chicago, and that's going to be a partnership likely with city and homeowners. So more to come there, but thanks for the question. Okay. Here's a question. What do we know about people getting reinfected with COVID? And I've seen that question also come through of, can you get COVID twice? That's another really hot topic for research. We've been talking about it here in Chicago, and we've started to see some good studies about this published. So first of all, there is definitely some evidence of individuals that have been reinfected with COVID, meaning that they had COVID once and then they actually get a second separate infection with COVID. But we do not think that this happens commonly. And let me tell you a little bit about what we know there. So there have been a couple now of case reports. As a reminder, a case report is an example of a single patient. But there's been a report out of Hong Kong. There was a report out of Nevada just in the last week or two, where there was someone diagnosed with COVID with all the best testing, who there was a sample taken that they were able to do the genetic analysis on and look at the RNA fingerprint for that COVID strain that they had. This person, in both cases, they recover, they have negative COVID tests, so you know that they've cleared it, and then they go on, after a number of months and have another new COVID test and they're sick with COVID. And they've been able to actually do the genetic analysis and show that the strains of COVID, both in like this case in Nevada and the case in Hong Kong, were different, that there were some differences in the genetic fingerprint, meaning that it was definitely a true new infection with COVID with a slightly different strain. But we don't think that this happens very commonly. We're still learning a lot about, immunity after someone has had a natural COVID infection. We know that there is at least some level of immunity, but we know that it doesn't necessarily last. And again, it won't protect you if there may be a slightly different strain, for example, which is why even people who have recovered from COVID, we need you to still be wearing the masks, protecting, not thinking now I've had COVID, I don't have to worry about it. We need everybody continuing to do those things that help keep everybody safe. But there was an interesting study. It's actually still in preprint, meaning it's not even out in the literature yet, but it was also just from late August 26th, out of the Middle East, out of Qatar. The lead author is Abu Raddad, ABU-RADDED, if you want to Google it. And here they actually looked at all the patients in again, a relatively short period of time that had lab confirmed COVID in that country. So they had about 130,000 patients. And they looked and they said, all right, how many of these people had another COVID test that was positive more than a month and a half later? It's not as good as sort of being able to do the genetic analysis and know that it's different. But what they were able to find was, first of all, that the number of patients who had another COVID test positive at least 45 days later was very low. It was about 243 patients out of 133,000, who had COVID. So that's that's like 1 per 1,000. And then what was interesting is they looked to see how strong was the virus signal in those patients using something called the CT threshold. It tells us how much virus is actually present when those folks were retested, because we do know that people can shed virus for a long time. And this is one of the reasons people will continue to have a positive COVID test even when they're not really thought to be infectious anymore. You have to stay isolated for those 10 days or until your symptoms resolve. But sometimes you can keep having a positive test, but that's not positive in a way that you can grow it on culture or that you're thought to be spreading it. So the question is, are these people who are just shedding virus for a long time, or is it a new infection? And so in about 54 of those 243 cases, the level of virus looked to be high enough that they thought, this is probably a reinfection. It's not as strong as that one case study of doing the genetic sampling, but it gives us a sense that, this probably is something that happens. But 54 cases in the context of 133,000 patients means the incidence is about 1 in every 10,000 patients. So where we extrapolate that out, it's really a low risk. It's existent probably, but it's not a high risk, and it doesn't throw, does this make me worried about the vaccine not working? No, it's nothing like that. But it just highlights, again, we're continuing to learn. At this point, it's pretty clear that it's possible, although not likely, that at least in the short term, in the sort of few months right after infection, that people could in fact get reinfected. We don't know what that looks like 6 months out. We haven't had enough time to be able to start answering those questions. But the bottom line is keep wearing those masks, keep the social distancing, even if you've had COVID, even if you have that antibody, as we continue to learn. Okay, here is a question. Man, we got lots of things coming in actually. Mona Lisa Davis on Facebook. My daughter works at a daycare. One of the moms stated that her daughter had tested positive for COVID-19. They are required to go and wear a mask. Should she go out and get tested to be on the safe side? Okay, so I don't know all the details of this exact situation. If this is about sort of an actual where there's been spread at a daycare, or there's been a child who's been diagnosed while at that daycare, if there's been contact within the, within 10 feet without the mask, that would be considered, a higher risk setting. If this is a setting where, the mask has been in place and distance has been, relatively good, which I know is hard in a COVID setting, there's not a requirement for testing. But I would say if let's say this is about the daughter working at the daycare. If your daughter's working at a daycare and she was working really closely with a child who was tested for COVID, I think probably that would be an example of something where, yeah, I would recommend probably getting tested. That's it's if she was wearing the mask, et cetera, that's a pretty good level of protection. But again, not knowing all the details, I would consider that, an exposure where certainly, to quote, be on the safe side, she could think about getting tested. Having the conversation, if you get a call from a contact tracer who says you actually have had an exposure and you need to get tested, absolutely you need to do that. I of course don't know the whole situation, but if, like anybody, if you think you've really had exposure to someone with COVID, then you then thinking about getting tested, you'd be in that second category. All right, here's a question. What's your take on the AstraZeneca news and how it halted the vaccine trial? So I'm not sure if everybody saw this, but I think yesterday or the day before, there was a lot of news where one of the vaccine trials, the one that is being led by AstraZeneca, or that's testing the vaccine being made by AstraZeneca, paused because there was someone in the United Kingdom in the trial who had a serious event. You heard I didn't say reaction because it's not known at this point whether that event was due to receiving the vaccine in the trial or not. But this is, my take on it is that this is exactly how vaccine trials are meant to work. Phase 3 vaccine trials are all about taking a vaccine that in the phase 1 and the phase 2, in the relatively smaller trials, the safety profile has looked good, the efficacy profile has looked good. This is where you give that vaccine to tens of thousands of people in the real world. Some get the vaccine, some get the placebo, and you study whether people in the real world have any kind of serious side effects. Is the vaccine continue to be safe in the real world? Does it continue to be effective in the real world? Do people who get the vaccine end up being more protected from COVID in the real world than people who get the placebo? And so it is not uncommon to halt a phase 3 study if there's a severe event. You need to do an investigation. If, for example, there's found to be another reason for why this patient, had an event that required her to be hospitalized, then that wasn't found to be due to the vaccine, then the board that monitors this, it helps actually explain a little bit how these trials work. The doctors and the patients in the trial are blinded to whether the patients are getting the vaccine or the placebo. But if there's an event, for example, where somebody has to be admitted to the hospital for any reason, like, say they, I don't know, they have some kind of flare of some other condition that they have. We don't know if it was potentially related to vaccine. If they get admitted to the hospital, there's a data safety monitoring board that will look at that data, unblinded, say, did this person get the vaccine? And potentially, as they did here, put a pause on giving further vaccine in the trial while they do that investigation. If it turns out that this vaccine actually has serious side effects, meaning, not just the sore arm or a small fever, but in the real world is causing any sort of serious side effect, that is exactly why the vaccine would not be approved. So I am not that I'm ever pleased to see an adverse reaction, but I am pleased because this is why we have good safety monitoring and good phase 3 trials. So, one potential event does not necessarily say that vaccine is done, but if it turns out that it looks like severe events, are linked to that vaccine, then yes, that vaccine would not be approved. And it would not be one that we end up being able to recommend, that the FDA wouldn't approve approve it. The CDPH wouldn't say we're ready to go. So it does not make me throw up my hands and say, oh my goodness, we're never going to get a vaccine. It says there was one event in this vaccine trial, and the safety monitor is working the way it needs to work, and that it will work. I am very confident. I hope people saw that many of the vaccine manufacturers were signing these public pledges, that they will absolutely continue all of the appropriate scientific rigor around these studies. We are not going to let the development of a vaccine be politicized. And I will be watching very closely, let me tell you, these vaccine trials and the process for a vaccine to be approved. By the time I take a vaccine for COVID, I will have looked at the data myself and feel confident that that phase 3 trial showed that it was safe, showed that it was effective, and I will share that information in detail with you when we have that. So that's what I have to say about that, and we'll be watching really closely. There are, as a reminder, more than 90 vaccines that are in trials. There are 30-something that are being tested in humans, and about 90 that are still in that preclinical phase where they're testing on animals or in the laboratory. And I expect a number of these vaccines are going to go the distance, be able to be proved to be safe and effective. But my biggest concern is that getting a COVID vaccine with a good safety profile. Again, we give vaccines to people who are healthy. It's very important that there are not severe side effects associated with that. That's the number one thing that has to be proven. And then number two, that they're effective. They may not be 100% protective against COVID, but if they are, at least, the FDA said at least 50% to 70% effective, or they're really good at keeping people from getting serious illness, that would be a big step forward. And we'll be watching that space. I remain confident that we'll likely see a vaccine near the end of the year, the beginning of next year, and I do think 2021 is going to be all about rolling that vaccine out. All right, we are coming up on time here. There's one question I want to highlight because it's often a question we get. Ebony Charday on Facebook said, I thought isolation was 14 days, now it's 10. This is one of the most confusing things. Isolation, meaning the time that someone needs to stay isolated if they've been diagnosed with COVID, is 10 days, and the last 3 days have to be without symptoms. That hasn't changed. The quarantine period is 14 days, and I know this is confusing. That's for people who have been exposed to somebody who has COVID. So like the woman who's asking about, the daycare and maybe I had an exposure. If that was a true exposure and she needs to quarantine for 14 days because it can take up to 14 days for COVID to blossom in somebody, for symptoms to develop, for the infection to take hold. And so I know that can be a little confusing, but that is the difference. 10 days is basically how long people can continue to be infectious and spread virus if their symptoms have been resolved. 14 days is how long we need people to quarantine if they've had an exposure. So thanks for helping clarify that. All right, with that, we are at time. We will be, or almost time. We'll be back next Tuesday. And we will be bringing Jenny Turner from the Chicago Department of Public Health on as the guest. She's going to be talking about our launch of Healthy Chicago 2025. As a reminder, this is our 5-year plan, not just for CDPH, but really for the city of Chicago. It's all about addressing the racial life expectancy gap in Chicago. This was our plan even before COVID, and COVID has brought this into strong highlight. So as a reminder, a week from today, September 17, 2:30 to 4, will be our virtual launch, and any of you are invited. But next Tuesday at 11 a.m. for Facebook, Jenny will be on talking a little bit more about that. I will take some more direct Facebook questions. Also, just on the good news front, at this point, we've signed up over 24,000 CPS, Chicago Public Schools, students and families for free high-speed internet throughout Chicago. There's also been a big push push to get devices out. Obviously, it's the first week of school. We are, as a city, able to cover tens of thousands more for people who are eligible for that high-speed internet. So to check your eligibility, if you are a Chicago Public Schools family and you don't have high-speed internet, it's really important that you get connected. You can go to cps.edu/getconnected. This is one of the largest programs in the country to ensure that even lower income families with kids in CPS don't get left off the digital divide. So please take advantage of that. And I think with that and timing, we will call it a day. Keep doing the things that know work. I'm hopeful next week we will be able to share some continued good news in terms of progress, not just on cases, but on that percent positivity. Tune in with us at 11:30 if you'd like to hear some more about lead service line replacement. And next week we'll be sharing some more information about contact tracing as well. So plenty happening on the COVID front. In the meantime, do what you know works, and be safe, Chicago. Thank you.